Good evening, everybody. My name is Swaans. I'm an interventional imager from the St.Antonius Hospital in Nieuwegein, the Netherlands. And welcome to this first PCR mitral focus group webinar on the new valvular heart disease guidelines and what these guidelines really mean for our patients with mitral regurgitation. I think what the new guidelines nicely show is that mitral regurgitation is no longer one disease with one treatment pathway, but it makes clear that we need to push ourselves beyond just grading these patients, but focusing on mechanism, timing, cardiac consequences, patient trajectory, and procedural feasibility. And what has changed is that we don't only look at what we can do for these patients, but when we should act and in whom. So tonight, rather than simply reviewing some recommendations, we will test the guidelines and get some real life cases. And I will be doing this together with my team of experts and friends in the field. So I have my co-host here for this webinar. He's Philipp Lurz. He's together with Thomas Mohamedine, the chairmen of the Mitral Focus Group. And on the other side, I have Fabien Praz from Switzerland, who is the chairman of these new guidelines. And last but not least, online, we have Maja, Cikes, a heart failure specialist. So thanks for joining us all. And without further ado, I would like to go on to our first case. But before moving to the first case, I would like to tell you that this is a webinar where you can ask questions. It's interactive, so please ask questions in the poll. And we also have a poll later on for voting. So be active and participate in this webinar, please. So the learning objectives is to differentiate between ventricular and atrial secondary MR regurgitation phenotypes and translate these phenotypes into the guideline-directed medical therapies and challenges to make a most appropriate therapy strategy for secondary MR patients according to the guidelines and phenotype. And maybe if we have time, we will discuss how early effective referral can treat and how you get these patients in your heart team. So the first case is going to be a case of a secondary ventricular MR. And I'm going to show you a case. So it's a 46-year-old male with dyspnea on exertion, and now he is in NIA class 3 to 4. Maybe good to mention, this is a patient that is in our outpatient clinic around 2020, 2021. In his history, he has an ambulant antral septal infarction in 2016. And since then, he has an ischemic cardiomyopathy with a left ventricular ejection fraction around 25%. And at that time, it was shown that he had postcapillary pulmonary hypertension with a PEP pressure of 47 mean and a wedge pressure of 35. He had some surgery for a neuroendocrinal tumor in 2018 and afterwards, unfortunately, asymptomatic AF leading to a kidney infarction, probably due to cardiac emboli. And before introduced in our outpatient clinic, he was actually hospitalized due to decompensation in 2019 and 2020, for which he required IV diuretics. Looking at his medication at that time, and he has been on this medication for quite some time already, he has apixaban, he has metoprolol 2 times a day, 50 milligrams, he has Entresto 2 times a day, eproneuron, empagliflozin, and furosemide, a little bit dose depending on the amount of fluids he's containing. So, looking at his ECG, we can see he has atrial fibrillation, but the most important thing, he has a narrow QRS complex. And then going to his transthoracic echo, where we clearly can see a depressed LV function with an antral septal infarction, clear scarred area where we can see left ventricular and left atrial dilatation. On the short axis where we can see there's leakage coming from the full line of cooptation in this patient, and also on the apical views is more or less the same with elevated RVSP. So again, to summarize the findings of the transthoracic, a large ventricle, biplane ejection fraction at that time was 13%, with 3D it was 15%, biatrial dilatation, and had moderate to severe MR quantified with an AROA of 0.32. He has mildly reduced RV function and a moderate TR and RVSP of 50. We did a coronary angiogram to rule out new coronary artery disease. Here we can see the right coronary artery in multiple projections, where we can see there's only mild abnormalities, but no significant lesions in the coronary here. And on the left side, we can see on the distal main stem, there might be a small indentation, but for this, an RF-FFR was done, and which was clearly not significant. And right heart cath have been done as well. So we see a mean pressure of 37, wedge pressure of 25, and V waves up to 40 millimeters of mercury. MRI is done, unfortunately not the best quality we had, but again showing a severely dilated ventricle. We can see the biatrial dilatation, also a dilated right ventricle. But if we go to the late enhancement images, although not fantastic, again we can see the antral, septal anterior wall is completely scarred towards the apex. So clearly the pattern of ischemic cardiomyopathy in this patient. So MRI conclusion, more or less what we have seen also on the echo. Clearly showing the infarction pattern on the late enhancement images. So ischemic cardiomyopathy with extensive transmural infarction in the LAD area, severe LV depressed function, and an MR and a TR. The ejection fraction was actually a little bit better now with 23% on the MRI. If we go to the TEE, and hopefully we can get this running again. Okay, here we go. Unfortunately, let's go back if you can get this one running. No, it's not willing, but it was showing a MR that's coming from the full line of cooptation, so clearly a secondary MR. And here we are just scanning in a normal way what we would do in all our patients with mitral regurgitation. So I like to do this standardized. So on the left we have the intercommissural view, now with an X plane to the center. So on the right side we see the long axis now showing A2 and P2. This is what we do without color and now with color. And the same is done. We move the X-plane line now more to the lateral commissure. Clearly on the right again, the lateral commissure is shown in a sort of LVOT kind of view. And again, with and with color, we do a systematic analysis to find out where the regurgitation is coming from, but also looking at the anatomy, immediately thinking about what kind of therapy options we have for these patients. And then finally, we do the same more or less in the LVOT view. By rotating the probe, we go from the lateral commissure to the medial commissure. So this is in the center. Then rotating the probe to the lateral portion of the valve, and then finally to the medial commissure. So a 3D looking en face, we can see that it's a little bit of asymptomatic valve where there's an opening more on the medial side a little bit more, and clearly also here a steel frame where we can see there's clearly coming leakage from the full line of coaptation in this patient. If we do a 3D venoconstrictor area, we can see the AOA or the VCA is very large, almost 1 square centimeter. So definitely a significant mitral valve regurgitation with tethering of the leaflet, what was shown here before. So a ventricular secondary mitral regurgitation. So to summarize again, a very young guy, 46-year-old, still has dyspnea on exertion near class 3 to 4, despite optimal therapy. We see an ischemic dilated cardiomyopathy with an ejection fraction around 25–20%, permanent AF, but a narrow QRS, so no CRT indication. He has no significant coronary artery disease, post-capillary pulmonary hypertension, clearly the scar on MRI, and a severe secondary mitral valve regurgitation. So the question is, what would you do in this patient? So do we have options to optimize the medication? Would you consider surgery? Would you have an MTR being done or another form of repair procedure, a TMVR, or more advanced heart failure care like an LVAD or a heart transplant? And there is a poll, so we can ask you to put in your answer in the poll. Please put out a poll.
Fantastic, Martin. That's a great case because there's so many different aspects to discuss, but it also reflects nicely our clinical daily routine. These patients, they can be complex, many things to consider. So we would like to involve you at home, our audience. Please give us your vote and let us know what you think is the best option here. Before we get the results in, let's discuss a couple of aspects here of that case. And let's start with the question of medication. Maja, is there anything to optimize? Is that something you consider GDMT in that very specific patient?
That's a great question. It's something that we always like to start with, of course, when discussing patients with heart failure. And as I've understood, this patient has been on quadruple guideline-directed medical therapy for heart failure for quite a long time, for several months, actually, even years. Perhaps, of course, we should mention that the target doses were not reached, but we should always respect the hemodynamic setting of the patient that due to hypotension was not able, which was also symptomatic, as I understood, was not able to tolerate higher doses And the opportunity for uptitration would perhaps be in the sacubitril valsartan and metoprolol for this patient.
Well, very recently, there is some evidence that digitoxin might be helpful. He's in AFib, that patient. Is that something you would consider in that patient?
Indeed, that's a great question. Thank you for highlighting that. The DIGIT-HF trial that was published recently has actually enrolled patients with chronic heart failure on very, very strong background therapies for heart failure. So all of the 4 pillars of heart failure therapies, ICDs, etc., and has shown an additional benefit of digitoxin on top of quadruple GDMT in the reduction of all-cause death and heart failure hospitalizations. Now, what's interesting probably to highlight is that perhaps we were mostly considering digitoxin or even digoxin from prior trials in patients with atrial fibrillation. And this is also what we have in our heart failure guidelines, a higher class, 2A recommendation in those with atrial fibrillation and 2B in the general heart failure population. However, in DIGIT-HF, we saw that irrespective of rhythm, these patients benefited from digitoxin therapy, and it will also be interesting to learn from future trials how this perhaps resembles with digoxin as well.
Yeah, but maybe a revival of that approach. Let's see what the future holds. I mean, obviously, this is an HFrEF patient. Every function is clearly reduced. The substrate is ischemic cardiomyopathy. But what's interesting is that there isn't a stand-in, and the myocardial infarction was ambulant. So you knew about the medical history, but otherwise the only other way to know, because on echo you might not differentiate between ischemic and dilative cardiomyopathy, was to perform an MR scan. Is that something you do very often in these patients, and is it particularly helpful for you?
I think if you don't know the etiology, I think this is crucial to do to find out what other options you have. I think the echo already clearly showed this infarcted area. So, and of course we knew this patient had an ambulant infarction. Unfortunately, not treated. He was in the hospital too late. I think it helps a lot if you're in questioning what to do for these patients. And I think we know that also the amount of scar tissue is a predictor also for outcomes of a lot of therapies further on. So I think MRI is definitely useful to find out what's wrong with the ventricle, to see the amount of scar tissue, and to find out if you're not aware of it, if it's a ischemic pattern or not, because it might change strategies, I think, for these patients. Although in the guidelines, I think the whole ventricular secondary MR, depending if it's ischemic or dilated cardiomyopathy, it doesn't really matter that much anymore. So, but still, I think it's important to know because it might change different strategies in these patients.
Fabien, you want to comment on that? Why do the guidelines not differentiate between ischemic or dilative in HFrEF and FMR?
I completely agree. I think the guidelines do not do this differentiation, and the reason is why there is no specific studies on this. We have some studies on acute patients with acute secondary mitral regurgitation, but not in the chronic setting, looking in that details of etiology that may be actually extremely important. So the study were including patients with both etiology and for this reason, the therapy that we describe in the guideline and that we will come back on are actually applying to both etiology.
We will discuss in a second about the specific options in that patient, but maybe the exact degree of ejection fraction could matter. You said on echo, what was ejection fraction?
A
little
13,
bit less.
15, less indeed than the MRI originally showed, yeah.
So MR was higher than echo in that instance. What shall we do when we have two imaging modalities? What can we trust and where would we expect lower or higher numbers?
So normally, actually, MRI gives you lower numbers, actually comparing it to echo. So personally, frequently, the MRI quality, although it wasn't the best in this patient, but MRI quality is, of course, much better frequently than the echo imaging and will provide you a more accurate quantification, although the methods of quantifying the left ventricular ejection fraction are not completely the same. That's why frequently on MRI, it's a little bit less than on the echo. I would assume normally about 5%, a little bit less. So for this patient, it was actually the other way around. That's indeed surprisingly, because we don't see that often. I think for this patient, the reason was because the echo, the transthoracic echo, was done when this patient was really in a decompensated state. So at that stage, he was just admitted. I think the ventricle was still under a lot of stress, having difficulties at the time. And the MRI, of course, you frequently postpone a little bit because the patient has to lay down quite still, doesn't need to breathe or anything. So the MRI was done at a later stage where the patient already had some diuretics, the ventricle was probably already a bit released of the tension, and probably that improved the LV function a little bit, yeah.
Okay, so numbers are numbers, but one has to appreciate that there are different modalities, and also ejection fraction can vary from day to day, but also from the investigator, from one to the next. NYHA class was 3 to 4. He had previous episodes of heart failure hospitalization. Maja, is this a candidate per se for advanced heart failure therapy, such as LVAD or transplant?
We should also definitely view this patient from the perspective of advanced heart failure. As you've pointed out elegantly, this is a patient with persistent heart failure symptoms, NYHA class 3 to 4. Somebody with severely depressed cardiac function and ejection fraction, certainly below 30%. The numbers that we're discussing are both below that. Somebody with repetitive heart failure hospitalizations, data on VO2 max, for instance, would be useful in addition, but we already have 3 criteria to define this patient as having advanced heart failure. So this is somebody that is 46 years old. In the context of the lack of comorbidities, this would be, of course, also a good candidate for LVAD treatment or heart transplantation. In general, we give a preference to heart transplantation, but with the improved outcomes with LVADs nowadays, we are, in this patient population, people in their 40s, even talking about net prolongation of life by primarily implanting an LVAD and then following that with a heart transplantation.
So we do have the results of our poll, and 15% argue that advanced heart failure care, LVAD or transplant is the next step in that patient. But the top answer was mitral TEER, 62%, and then another 8% for medication surgery and mitral valve replacement. So mitral TEER seems to be the preferred option. Fabien, what do the guidelines say in particular in that patient? What is the recommendation for mitral TEER, and is that a substrate where success or benefit is very likely?
So that's a borderline case, I would say, and we discuss this very nicely now because we have different numbers in terms of echo. And it shows also, Martin, I think, the power of medical treatment, because obviously between echo and MRI, you had an improvement of LV function that was probably related to the medication you started. So looking at the LVEF, I think if we are above 20%, and you see the criteria just on this slide that are also in the guideline, then we will be in the co-opt population, co-opt reshape population, because these criteria have been adapted after the publication of the reshape trial. And Maja just mentioned the discussion about one of the points that is lower in this table regarding stage D of advanced heart failure. Certainly something we can discuss because the patient was hospitalized, but still, I think he was still active. You mentioned this before, Martin, and still somebody that could function despite of having symptoms of heart failure. So probably a debatable situation for this patient, but I would argue that this patient could fulfill the criteria that are now a class 1 indication for edge-to-edge repair after optimization of all other factors, medical treatment, and also cardiac resynchronization. And from the other value, I think he's still in the range. If you look at the left ventricular and systolic diameter, or the systolic pressure, the systolic pulmonary pressure, we are in the range. He has no severe tricuspid valve disease, so a patient that could benefit from a prognostic point of view from edge-to-edge repair according to the trial, at least for reduction of rehospitalization.
So you agree with the audience in the poll. Martin, let's see and hear what you have done.
Yeah, indeed so, but let's see, because the case is a little bit different. Initially, for this patient, I would say advanced heart care makes sense. So we discussed the patients in advanced heart care planning and to see what the options were. But the patient is planning to move to South Sudan to live with his family, and he's going to a rural area where actually access to medical care was going to be a problem. Also, his medication already was going to be a problem, but especially putting this patient to an LVAD or a heart transplant or giving it advanced heart care options was definitely not an option for this patient. So he already rejected also because of this reason the ICD, because this was of course missing as well in this patient, but he knew exactly, we highlighted him and he didn't want to have the ICD, but at that point we discussed, so let's see what we can do. And since he was still decompensating a lot and GDMT couldn't be optimized, we said, okay, what we're going to do now is we're going to give this patient an MTR procedure, because we simply want to get him out of the hospital and hopefully improve his quality of life, because he's been in and out a lot and significantly having symptoms in his daily life. So what we've done, and we have seen these images already, but again, there's an MR coming from the full line of cooptation. We went in, and I think we have all seen this procedure, so I'm going to skip over. But what we've done here, if we put in 2 mitral clip devices in the center of this valve, we can see clearly opening is good enough, so there's no turbulent flow or anything. We drilled this nice tissue bridge in the middle, and where we can see at the end of the procedure, I would say, only a trace of MR is left. But the nice thing, and I really love this phenomena during the procedure, is that during the closure of the second clip, we saw a rise in blood pressure about 15 to 20 millimeters of mercury. So I think you can clearly see at that time that hemodynamics really improved for this patient. He got more output, and that's, I think, a good sign that we know this patient will benefit of it. So this is what we saw afterwards. Actually, on the short term, we saw he had a significant improvement in quality of life. He moved from 3-4 to a near class 2, of course, still having this ischemic cardiomyopathy. So near class 1 would have been ideal, but not going to happen. But the nice thing is, and as we already saw also during the procedure, there was an increased and significant increase in blood pressure, made it possible to up-titrate heart failure medication in this patient even more. And he hasn't been hospitalized afterwards, but actually because he was still planning to go to Sudan, but then the COVID kicked in and he was sort of bound to the Netherlands for a longer period. And we saw him quite recently on the outpatient clinic again, but because he still haven't moved, he's been quite fond of the Netherlands now, but still has the idea to move forward. And this is what the echo looks like. So we still see his poor ejection fraction, of course, that didn't change, but we can see the clip is nicely in the center being in place. We see the opening, but I think still an excellent result of the MTR procedure after more than 5 years now, having a trace of mitral regurgitation. And I think he's doing still fine. So we're very happy with the result of this case.
Very good. Fabien, a quick word about the risk of LV failure during the procedure or immediately after the procedure, given that the baseline LV function was really poor. Is it something you see often? Probably not, but is it something we should consider and can be predicted?
So I think this should be considered, in particular if the LVEF is so low. He's a young patient, so I would be a bit less concerned that this happened, but in older patients, this can be a risk. I don't see it so much, I have to say, during the procedure, because patients are still with a low afterload, and the problem can start, I would say, afterwards. But it still is something we don't know so much about because the cases are very rare. But I agree that we need to be aware of this, that this can happen, and also be very attentive on the follow-up of the patient, just on the day 1 and 2 on the ward, because this is actually the period that risk much more than during the procedure.
And then we do have a question from the audience regarding the intervention and device selection. So that was a clip case, but the other device, the Pascal device, also comes in different sizes, the larger and the smaller device. And the question is, how do you decide between a P10 and a P5 in such a case?
So I think, first of all, if we talk about the choice of the device that was done by Martin and his team, I think that makes sense because obviously the clip provides a very strong annuloplasty in this kind of secondary mitral regurgitation patient. And it's also the device with the most evidence, I have to say, in terms of randomized control trial for this population of patients. But probably the same happens when you use a Pascal device. In terms of choice between one side and the other, I think the device that is the most frequently used is the ACE for the Pascal, because it provides probably also a bit more annuloplasty compared to the bigger size, which is a P10. But some people like to use it as well in secondary mitral regurgitation, not so much in primary. But personally, I would use an ACE device, and I think Philipp, you probably as well.
When using a Pascal device in that instance, yes, an ACE, because I think that the annuloplasty effect and the strength, how to pull on the leaflets is greater with the ACE device. Maja, I'd like to be a little bit, I'd like to provoke a little bit here. We do have great data that treating FMR in HFrEF patients reduces heart failure hospitalization. We also, from the co-op trial, have great data with respect to mortality reduction. And that patient did much, much better. And we have a 5-year follow-up. But how can we explain that with still such a poor ventricle, that the reduction or almost abolishment of MR conveys so much benefits? What are the mechanisms?
So one of the mechanisms is, of course, the reduction of wall stress that we are gaining with unloading of the patient. We can also benefit from a reduction in the need of requirements of diuretic therapies that the patients in heart failure need as least as they can obtain. And of course, the up-titration of their GDMT hemodynamically. Hopefully the patient was more stable, and as it was pointed out, they could tolerate higher doses of GDMT. Now, the fibrosis, the large scar burden that the patient has cannot be reversed. That is obvious, and I think we can all appreciate from this echo that the structure and the function of the ventricle hasn't changed dramatically, but it's creating hemodynamic circumstances with which the patient is, flying quotes, in stable heart failure. But as long as this is giving us room for optimization of therapies, and we were discussing also the option of using digitoxin, perhaps digoxin as well, vericiguat, are these all drugs that we can use in these patients? And in some way, I would presume delaying heart transplantation in this person is an excellent gain. So this young man has now gained already 5 years in their heart failure trajectory. It's still quite likely that they may be a heart transplant candidate at some point if this is required by their clinical status. Now they're in NYJ class 2, which is perfect. Of course, we're not going to transplant them just because of a low ejection fraction. But the longer we can delay this, the better for the patient. Again, heart transplant will gain an additional 10 to 15 years of their life. And if we delay this into their 50s or so, this is excellent net prolongation of life for the patient.
Yeah, I think that's a very important point, because sometimes heart transplant is considered as the definite treatment forever. But as you said, it's worth to delaying it, because you gain 10 to 15 years, but you will not gain 30 or 40 years. And this is a young patient. Great.
We can do redos, and of course, who knows what the future brings in 10 or 15 years in terms of additional devices. But if we have a tangible option for prolonging this is always excellent. But we do need to be careful in patients with advanced heart failure, of course, how they respond.
Philipp, maybe I have a question for you, and for you, Maja, regarding the post-procedural care of this patient, because obviously it does not stop now with a clip in the patient, and probably the patient has been followed up at your center very closely. What is your hope, Philipp and Maja, on being able to improve medical treatment? Is that something that is important for the prognosis of this patient? What do we know? Philipp first, maybe.
I strongly believe that one of the main benefits of treating MR is obviously, as Maja nicely illustrated, that you reduce wall stress, and it's a good thing not to have that much MR. But the other benefit, and this is also why the trials are so obvious, is that you can improve GDMT. And there's no doubt that GDMT is very useful for these patients, and the more you can up-titrate, the more drugs you can add, the better it is for the patients. And I think, Martin, you and your team, you've done extremely well in making sure that up-titration is possible. You nicely explained why it is possible, because you improve hemodynamic stability, you increase blood pressure, sometimes you even improve renal function, which can also be a limitation for not up-titrating GDMT. So it's not just treating MR, it's also treating MR to optimize better GDMT.
Maybe Maja?
Absolutely, I agree. As much as we can sustain the maximal doses of the wide therapeutic options we have for patients with heart failure with reduced ejection fraction, the better for the patient. Of course, we don't have clear trials that test this in patients post-TEER, but if we follow the standard hemodynamic presumptions that we have in these patients, and of course, this still is a patient with heart failure with reduced ejection fraction, we do expect tremendous benefit and life gain for this patient with the best we can do with GDMT. And also, let's not forget down titrating their diuretics whenever possible.
Just one question, Maja, as well, because the uptake, I think, of MTER in the heart failure community is still challenging, I would say. So we're still struggling to convince you as a community. So what to do, and how can we convince and change your guidelines as well, that we can put this as a real fifth pillar in the armamentarium of our patients?
Well, I think the results of the poll were really interesting. It was a little bit of a selection bias in the audience. I presume that the majority of our audience today are people that are more diverted or more localized in the interventional community, but whether it is imaging or interventions per se, rather than the heart failure community. I would be interested in seeing the results of the same poll in a heart failure community, just as you're highlighting. You know, we're all seeing these patients from our own silos and somehow seeing them either as a valvular patient or seeing them as a heart failure patient or seeing them as an ischemic cardiomyopathy patient. But the more we communicate together and have efforts such as this one, I think the more our eyes will be opening towards different approaches. Each patient is individual. In some of them, this would not perhaps be the correct choice. In others, super convincing and very successful for your patient. Congratulations. So I think we always really need to come together and discuss what is best for each patient individually to try to aim for the ideal or at least best treatment solutions we can find.
Great. Thank you very much. I think for the sake of time, we move on to Fabien for the second case, and he will be discussing secondary atrial mitral regurgitation. So, Fabien.
Yeah, thank you very much, Martin and Philipp, for the invitation. I just would like to emphasize that it's the first time that guidelines are making the difference between these two very different phenotypes, atrial and ventricular. So thank you for discussing this in details and showing also concrete clinical scenario in patients. So my patient of today is an 82-year-old man that presented again with heart failure symptoms. It's all about heart failure and shortness of breath. He went in NYHA class 3 at presentation, and he had paroxysmal atrial fibrillation when he presented in 2017. That was the first presentation and also the first symptoms of disease, which is atrial fibrillation. And he presented with something special that on echocardiography that an LVEF of 35%, so an heart failure with reduced ejection fraction that was thought at that time and interpreted to be due to uncontrolled atrial fibrillation. And then as a combination, I would say, of this reduced ejection fraction, he had also moderate to severe atrial secondary mitral regurgitation. We checked for coronary artery disease, and obviously he had also an MRI. I did not show here because it was not showing any other finding, but confirmed the diagnosis of tachycardiomyopathy. And also chronic renal failure, which is very frequent in this older population of patients. So he came in with symptoms, was sent by the general practitioner. That's a pathway of many of our patients. He come to an imaging specialist like you, Martin, get a TOE or a TTE, and you see the situation is on uncontrolled atrial fibrillation. The LVEF is reduced, and he see an heart failure specialist. He had at that time also, I mentioned this, moderate mitral regurgitation. So what would you do in that situation? An older patient that has symptoms and heart failure, you will start medical treatment as first, and that's a poll the audience can participate in. You will go first with wind control. You will go for rate control because that's an older patient. But remember that he presented in 2017, so he was much younger at that time. He was 75. Surgical treatment of the mitral valve, transcatheter edge-to-edge repair from the beginning. So that would be the option. Maybe I can repeat them: medical treatment, rhythm control, rate control, surgical treatment of the mitral valve, or transcatheter edge-to-edge repair. He was 74-year-old at that time.
It will take a minute before we get the results of the poll, and we use the time to ask you, Fabien, the question. All 5 options obviously are doable and should be considered. Do the guidelines help us to decide?
So I think the guidelines help us because they say that this kind of patient, and I think it's very important, also for your patient, Martin, need to be seen by all the specialists I mentioned before. So basically, this patient would need, according to the guideline, to be discussed in a heart team, maybe to be seen also by different specialists, an electrophysiologist, an heart failure specialist, and maybe also a cardiac surgeon. So that would be the first step, actually, that would be recommended by the guidelines. Maybe I continue, and then we can look at the result of the poll. So our option there, after all these steps, was actually to give the lead at the electrophysiologist, because the different specialists seeing the patient were thinking that the main problem is actually the rhythm of this patient, and that was an attempt to keep the patient on sinus rhythm. And that's actually also what the guidelines are saying. So if the team of specialists taking care of this patient with atrial secondary mitral regurgitation come to the conclusion that it needs optimization of medical treatment or rhythm control, then this is the first step that is shown also on the algorithm on the left. So this patient had uncontrolled atypical flutter and atrial fibrillation, a complex disease, and he was put first, of course, and Maja, I'm sure you are happy about this, on medical treatment as well, because you remember his left ventricular ejection fraction was reduced at that time. So medical treatment was very important to support him as well. So you can see that he got diuretics, he got spironolactone, and also metoprolol. Philipp?
We do have the results from the poll, and the top answer is rhythm control, 46%. And then we have 23% rate control, medical treatment 15%, edge-to-edge therapy 15%. But there wasn't the option, obviously, to combine, as you have nicely shown here, rhythm control and GDMT.
So obviously we agree on this. I hope I did not influence too much the audience, but I also think it's a way to go, of course, including medical treatment first to react to the reduced LV function. So the patient had a quite complex rhythm problem, as you can see here, but a lot of effort went done to put him back into sinus rhythm. So he had 3 ablation of a different load C during several years. And that was quite successful, actually, because until 2024, so for more than 7 years, he could stay with a successful procedure into sinus rhythm, and you see it here. He also had this SGLT2 inhibitor with time, because some evidence was supporting also the use of SGLT2 inhibitor in patients with reduced or preserved left ventricular ejection fraction. And you can see that there are some data, very limited data, but supporting this approach that you can reduce tricuspid regurgitation and mitral regurgitation by keeping or trying to keep patients actively in sinus rhythm. And this can be different strategy, cardioversion, ablation, or also medical treatment. And this worked quite well, as you can see in our patient, until 2024, with mild or mitral regurgitation going back to mild. But then problems started again in 2025. The patient had recurrent atypical flutter. The problem he had at the beginning came back. He had immediately progression of symptoms with a failure, obviously, of sinus rhythm restoration, despite all the effort. And it was decided, because of the symptoms and because of the failure of other strategy, to do an AV node ablation and to have a pacemaker lead with a left bundle branch block area pacing. And the patient at that time only was then referred to our heart valve clinic for looking at the mitral regurgitation. And what you can see here is that the situation has changed a lot compared to the images I showed you from 2017. You see that there is a huge dilatation of the left atrium with very planar coaptation. And what you can appreciate also is cleft, an indentation of the posterior leaflet that is not involved into mitral regurgitation, as you can see. So this indentation is closing during systole and not leading to mitral regurgitation. And what is interesting is that the patient developed also secondary tricuspid regurgitation with time, probably not so much due to the lead that was implanted in between, but more to the dilatation of the right ventricle. And you see that this tricuspid regurgitation is quite complex with a stellar regurgitant area and something that is maybe not so easy to treat or to repair. I mentioned this, and you can read this in the guidelines with the differentiation between atrial and ventricular secondary mitral regurgitation. And I encourage you really to make this differentiation between patients. There is, of course, forms in between. And this patient is maybe something on the way to the development of ventricular SMR as well, because you see that he has a second form of atriogenic mitral regurgitation with pseudoprolapse and also some degree of restriction of the posterior leaflet that you could appreciate of the previous images, that this patient typically have a less good result after edge-to-edge repair and also a less good prognosis. Very important disease to be treated exactly the same as ventricular mitral regurgitation, because the prognosis, long-term prognosis of this patient are really bad. Cardiac catheterization was done as well. It just confirmed the relevance of mitral and tricuspid regurgitation. And because the anatomy was complex for edge-to-edge repair with a lot of big jets and this indentation, we also tested the hypothesis, I would say, of replacing the valve. But you can see, and that's also a sign of late presentation. You can see that the annulus was very dilated, already above the range of any replacement device. And also the left atrium was extremely big, as well as the right atrium, as a sign of very advanced disease. So I come to an end of the presentation of the patient, 82-year-old man, and then I think we will discuss a little bit this aspect. He is still symptomatic despite multiple efforts to maintain sinus rhythm. He has chronic renal failure, preserve left ventricular ejection fraction now after treatment of atrial fibrillation, severe atrial secondary mitral regurgitation, and that's the medication he had at the presentation this year.
Great, Fabien, an excellent case and a good example of an atrial secondary mitral valve regurgitation. First thing I would like to discuss is, again, going back to the heart failure specialist, because it always starts first with the medication. I think we have seen that the patient goes a little bit up and down between tachycardiomyopathies, HFrEF situations, and when he's in sinus rhythm, being at the HFpEF more kind of situation. So, Maja, looking at this medication, is this sufficient enough, or would you treat the patient more aggressively, also like an HFrEF patient?
That's a great question. And I think that in essence, this is a patient with typical heart failure with preserved ejection fraction who then deteriorates in his episodes of atrial fibrillation that is also tachycardic. Now, while we have many pharmacological options of treating heart failure with reduced ejection fraction, let's all remember how fortunate we are only in the past few years, in fact, only in the past 3 years or so, with new therapies for heart failure with preserved ejection fraction that do indeed somehow mostly overlap. These are SGLT2 inhibitors and MRAs, specifically with non-steroidal MRAs that have now a clear positive phase 3 trial, specifically finerenone for patients with heart failure with preserved ejection fraction. Whether one would be more persistent with therapies with a quadruple GDMT in this type of patient, that probably wouldn't be a mistake either, because this is somebody with heart failure with improved ejection fraction, yet another term we like to use for the categorization of our patients with heart failure, where we know that withdrawal of GDMT can lead to worsening. In essence, I don't think this is the case in this patient per se. This is not somebody with an ischemic or dilated cardiomyopathy that originally presented with HFrEF, and then you took off the therapies. Then you continue with the therapies. They went to have PEF, but with the withdrawal of therapies, they went back to REF. In essence, this is a patient with heart failure with preserved ejection fraction with occasional rhythmological episodes of worsening. Quadruple GDMT, again, probably would not be an error here, but certainly we do need to keep 2 SGLT2 inhibitors and non-steroidal MRAs in this patient. It's a whole additional topic of discussion whether we can put a sign of equation between steroidal or non-steroidal MRAs. The data are compelling currently for non-steroidal MRAs, but until recently, I think a lot of us in the heart failure community were using steroidal MRAs, as you have been doing in your patient as well. So using spironolactone before we had finerenone available.
Great, thanks a lot. And just to go back to your case, Fabien, looking at the left atrium size, which is enormous when the patient was presented here, and what do you think of the timing that the patient was referred to your center? Did they stick too much to the ablation side too long, or didn't pay attention to the regurgitation enough up front? What do you think about this situation here?
That's a good question. I think the strategy was quite clear, and the workup of the patient has been done in a good way. So it was, as Maja mentioned, it was quite clear from the diagnosis that atrial fibrillation is probably the thing that is making this patient really symptomatic. Maybe, as a bystander with FPEF. So I think the strategy was not wrong, but maybe as an interventional cardiologist, and you mentioned this, Maja, we see it differently from our perspective, but I would have liked to be involved a bit earlier in the course of this patient, to have maybe more options, because you saw already that this patient could not be treated anymore with replacement, despite the fact that the anatomy was not ideal for edge-to-edge repair. So I think as a message, probably not wrong, but I would say, involve your colleague very early in the strategy of this patient.
Yeah. I think we see that quite a lot, that the EP guys take a lot of care of the rhythm, just focusing on the rhythm all the time, but actually forget to do echoes or anything to follow up these patients. And in your setup, maybe Philipp, how do you get them engaged? How do they get these patients being followed up? Do you have regular consultation? Do you speak with your EP guys to?
It's always good to talk to each other.
Anyway,
there is no doubt. And I think that we are all slightly prone to think about what we do every day. And there is no doubt that the treatment preference is sometimes slightly biased according to the specialty, but I think we all agree that it shouldn't. We shouldn't decide on what we like to do. We should always decide what is best for the patient, and therefore we have to connect with each other better. We have to talk to each other. We have to improve the heart team, and we have to make sure that everybody is interested in doing the best for the patients.
Yeah. Yeah. Do you also think that we have to be more aggressive with catheter ablations, maybe not to wait too long with medication, and be more aggressive to really modify the disease itself instead of waiting till the left atrium to enlarge?
I agree. It's in both ways. Yeah. And I think what we don't know exactly is, first, how successful is the ablation in the presence of significant valvular disease, of regurgitation. And on the other way, I think that atrial fibrillation could be something that entertain MR even after an intervention. So I think it goes on both ways, and we really need to have more data, but also maybe to discuss this patient more and the timing of each of the procedures.
Good. I think maybe we should move to the case back first before we go on a discussion again.
Sure. So what we decided to do, as you can imagine, is to do an edge-to-edge repair, because we had no other option, and the patient was, because of the age at that time and the time he presented to us, was quite high risk. And there are some supportive evidence we don't have randomized data for patients with atrial mitral regurgitation, but we start to have some supporting evidence that compared to medical treatment, the reduction of MR using edge-to-edge repair could be an advantage. So you see the procedure, and again, I don't go into details because that's not the purpose, but as you, Martin, we actually choose also a mitral clip in this patient, probably for the same reason, because we wanted to ensure as much as possible annuloplasty, because the anatomy was really, really big in that particular case. And that's the final result. So it's not perfect, and that's often the kind of result you get. You see that we already had a gradient of 4, so we did not want to go further with a third clip. We had 2 implanted. but further quite good result actually for this anatomy. You remember that there was also an indentation of the posterior leaflet. And that's the follow-up of the patient. So the patient is really doing very well. He has no cardiovascular symptoms. He's not extremely active, but is actually very happy. And what we observed, which was quite interesting and may also go into the direction of late treatment, is that we had some drop of the LVEF after treatment of the mitral valve. So I don't show you the mitral valve. It's not the result after MT, but it's a TR, because I think that's also a point for the discussion. And we are just 3 months after treatment of the patient on the left side and still have persistent TR. The patient is not very symptomatic, but still that's maybe something we could target in the future if he would be symptomatic again.
Very nice. I think a beautiful case indeed. And I think looking at this, if he was younger, because looking at the guidelines in this kind of patients, actually surgery gets a higher class of recommendation, so a two-way recommendation. Does it make more sense to do this? Because it's frequently an annular kind of dilatation, so for putting in a ring like surgery. Are we underusing this in the population? Because MT, of course, is easier to offer. Patients like it because there's less risk in the procedure. What do you think? Are we underusing this indeed, or?
So, the thinking of the task force in the guideline you mentioned, there is a two-way recommendation for surgery, a 2B recommendation for edge-to-edge in this population of patients when they are high risk for surgery. And the thinking was exactly the one you mentioned, that the opportunity for surgery to do all-in-one procedure, meaning an ablation of atrial fibrillation and annuloplasty, which is really counteracting the pathophysiology of this disease, but also the opportunity to do LA occlusion surgically. And we have to mention also as well the treatment of tricuspid regurgitation that is often associated with this disease. So all this together was actually in favor of having this patient, or of this patient being good candidate for surgery if the risk is low, and we don't have so much data as well. But probably this is the first line strategy, and edge-to-edge repair, which is not always easy in this anatomy, came as an alternative for many patients at high risk.
Maybe Philipp, because now we have used the TEER device again. The main problem is annular dilatation in this, so we're treating the leaflets instead of the annulus itself. Does it make sense, or do you think that maybe in the future we will get newer devices or different treatment to treat this, or do you think MT will be a very good option still in these patients?
The fundamental principle why TEER works in functional disease is because by pulling on the leaflets you get an annuloplasty effect, and that's true for ventricular FMR, but ideally you should also get the same effect for atrial FMR. In atrial FMR it can be more difficult to pull on the leaflets for the reasons already described. So whenever you do TEER, you have to think not about a leaflet therapy, but about a therapy which should provide an indirect annuloplasty effect. Other approaches which can also offer that annuloplasty effect, I'm absolutely convinced, will work. But so far we don't have devices or approaches interventionally which are not too complex and reproducible. And then obviously for surgery in younger patients, when you can do a great annuloplasty, then patients will benefit.
Yeah, great. I think you already mentioned it, because frequently we'll see in anatomy here as well that the leaflets are quite flattened, less mobile frequently. Also the AMVL is less mobile. What is your biggest concern? What are you looking at during your procedure? Is it the gradients? Is it MR reduction? Because are you afraid of getting gradients or reduced mitral valve openings in these patients?
So obviously, I think, and we can discuss with Philipp or yourself as well, I think the patient with atrial mitral regurgitation are always quite challenging for edge-to-edge repair because they have very frequently a lot of MR along the coaptation line, and they develop gradient as well because these leaflets are not so mobile. They are kind of elongated and not so mobile as you would expect. So after one device, you can already, despite having not reduced mitral regurgitation as you want or perfectly, you can already have significant gradients. So it's always a balance that is not so easy to achieve. and obviously not easy patient to treat. Philipp, do you agree, or what is your experience?
No, I absolutely agree. I mean, there's no doubt that when you do it well, patients can benefit a lot. And in some cases, you get excellent results. But it's not easy to predict the outcome of a TEER procedure in atrial FMR. I think it's easier to predict it in ventricular, and it's something where we need to get better.
Yeah, and do you think looking at the echo or looking at the images, there are predictors where you can predict this might be a more challenging case for a TEER, or is it still?
The more hamstringing you see and the more flattening of the leaflets, then it's more difficult to predict. But even in those cases, sometimes you get great results. But I think we have to be honest enough. You can always reduce it to some degree, but it's not easy to predict as soon as some degree of hamstringing of the posterior leaflet is seen.
Yeah, agree, Fabien?
No, absolutely. I think the issue is the coaptation reserve you are able to have again, and that's much more difficult in that kind of very flat leaflet to restore compared to secondary ventricular mitral regurgitation. There, when you put a clip in the middle, you can restore coaptation right and left, and that's much less the case for atrial secondary MR. So something we still need to know more, and we need more data. I mean, we have very small cohort of patients, and data are needed to understand a little bit better how they do.
I think so. As looking as well, we mainly are basing ourselves on registries at the moment at atrial FMR, and the rest, the real evidence based on RCTs or anything, we still need to come. So, looking at the echo now, because we still have the severe TR, and it's always a combination which we see quite a lot because the biatrial dilatation, we have significant mitral regurgitation, we have significant TR, and sometimes even the TR is bigger than the MR actually. So, staged versus combined, because there might be some data combining this in one strategy might be better than doing it staged. So how does it work in Mainz for you?
So we know from evidence that when you fix both valves, patients do better. And whether you have to do it immediately in one procedure or staged, that's something we still have to answer. Treating atrial, mitral or tricuspid regurgitation can be complex. And if you add too much complexity in a combined procedures, then there are also some disadvantages. So far, we do these combined procedures when patients are very fragile or when you see significant right to left shunting, because then you don't have to close the ASD, you just have to fix TR and then right to left shunting disappears.
Yeah, is it the same for you, Fabien? In your center?
So all these factors are very important. And you mentioned ESD, very important, very interesting, because as soon as you treat the left side and you have severe TR, this can be an issue. People tend to say, and I agree with that atrial etiology will not improve so much when you treat the left side and leave the right side. I think the etiology is making actually the improvements a little bit more difficult. So I would tend to treat it in a combined procedure for improving the patient.
There's a question: what you should treat first, tricuspid or mitral? Always mitral, correct?
Yeah, absolutely. So I would always treat mitral first, and that's something we see. Maybe we can discuss as well very quickly. I would not treat the tricuspid valve then if the result on the mitral is not perfect as well.
And then one quick question with a quick answer from Maja. One question was about GLP-1, because BMI was more than 30. Do we have any evidence in these instances?
We have a clear trial that shows improvement in quality of life for patients with heart failure, preserved ejection fraction, and overweight obesity. We also have some data suggesting improvements in cardiovascular outcomes, heart failure hospitalizations, and death. And of course, we are awaiting larger data from current ongoing trials. These are all mostly focused on patients with overweight and obesity in the heart failure arena. So stay tuned.
Great. So Maja, Martin, Fabien, thank you very much for your expert contribution, and special thanks to our audience for joining us for this webinar. We had a 360-degree discussion on the care of patients with FMR, different etiologies. I think you've seen that we have more options now, we have more evidence, we have better guidelines, updated guidelines, But we still have to make the right decision. And this decision might depend a little bit on the subspecialty which is involved, but there is no doubt that we have to involve all specialties. We have to make the decision which is best for the patients. So we need to connect with each other a little bit better. So this is a clear appeal to the heart team. Group up with everyone you have in your hospital, with all the experts, discuss the patients together, and then come to the perfect decision for the best of the patients. That's one of the goals we do have in the mitral focus group, to connect the different disciplines in a much better way and overall to improve the care of patients with mitral valve disease. There will be more activities and initiatives. Please stay tuned and have a perfect rest of your evening. Thank you.
Thank you.